Well, I think most people treated for hypertension these days require more than one drug, and inevitably we've moved to the whole debate about whether more people should be using single pill combinations on a more regular basis, and even starting treatment on single pill combinations. I think the first thing to say is that single pill combination therapy will result in better blood pressure control overall, which seems pretty obvious as you're using more than one drug. But importantly, secondly, we also see that these patients tend to get less side effects, particularly if you use the right type of combination. Because, for example, combining a RAS blocker with a CCB can reduce the risk of edema due to the CCB. Combining a RAS blocker with a diuretic can reduce the risk of hypokalemia. So generally, you get less side effects and more efficacy, which is always a good deal. The next issue really is the fact that no patient has the same makeup in terms of the underlying pathophysiology of their hypertension as another one. So when you see a patient with high blood pressure, you don't know whether they're going to respond best to a drug that blocks the RAS system or whether they're going to respond best to a diuretic or a CCB. And so if you give them a combination as treatment, then the chances are they're going to respond more effectively to a combination because you're targeting more than one mechanism and therefore have a greater chance of targeting the right mechanism. And that's important because, of course, if you use a diuretic or a CCB on its own, even if it works, it won't work to its full effectiveness because you'll activate the renin system with these drugs, and therefore blocking the renin system will add to the value of the other drugs as well. So I think the combination of a RAS blocker with either a diuretic or a CCB is increasingly seen as the preferred therapy for most people with high blood pressure. There's been considerable debate about which RAS blocker to use for the treatment of hypertension. We're in the fortunate position that we have two classes of RAS blockers with good evidence, ACE inhibitors and angiotensin receptor blockers. And you know, it's often down to a clinical decision by the doctor about which drugs they want to use. But what I think is that when you look at hypertension, you're dealing primarily with a chronic asymptomatic condition where the quality of 24-hour blood pressure control is really important. And where it's undoubtedly true that angiotensin receptor blockers have the edge over ACE inhibitors is in the fact that they are better tolerated than ACE inhibitors because they're less likely to cause cough and other side effects. In fact, ARBs are better tolerated than almost any other type of antihypertensive treatment. And secondly, ARBs have a longer duration of action. And even the shortest duration of action ARB has a longer duration of action than the longest acting ACE inhibitor. So I think ARBs are genuinely once-a-day medications. I think with the ACE inhibitors, unless you're using very high doses, these drugs often are best given twice a day, particularly for the treatment of hypertension. So the simplicity of giving a once-a-day drug and the absence of side effects and better tolerability steers me towards the preferred use of ARBs for the treatment of hypertension. Well, there's been huge controversy and discussion about whether ARBs or ACE inhibitors are more effective than each other in terms of reducing morbidity and mortality. I think it's largely a discussion that's being generated by the pharmaceutical industry itself, because when I was chairing the NICE guideline, we looked very closely at this issue because in 2011, one of the comments from our GPs was that you said last time in your guideline that you could use an ACE or an ARB. Which one would it be? And previously we'd steered towards saying, well, it should be an ACE and then an ARB if it wasn't ACE, if the ACE was not tolerated. But in 2011 we changed our recommendation simply because when we look at the comparison of ACE inhibitor versus ARB in clinical trials, we could not determine a meaningful difference between them in terms of their ability to protect against major outcomes, including death. In fact, you know, the only head-to-head trial that's ever been done directly comparing an ACE inhibitor with an ARB in a population of patients who had been hypertensive but were treated when they went into the trial in the most part, with the on-target trial, which effectively replicated the type of design used in the HOPE study, which in many ways validated the ACE inhibitor as a treatment for hypertension in high cardiovascular risk. And the on-target trial clearly showed that the outcomes for the ARB, in this case telmisartan versus the ACE inhibitor ramipril, were identical. There was literally no difference in 25,000 patients with high risk of cardiovascular disease. NICE looked at that independently and came to the same conclusion, and therefore concluded that we can use an ACE or an ARB when we are treating hypertension according to the NICE guideline. But as I've already said, I personally think the ARBs have the advantage over duration of action and tolerability, particularly when treating hypertension. In terms of the debate about morbidity and mortality, the only way you can really address it is head-to-head trials. There have been a number of meta-analyses that have tried to compare data from trials with ARBs versus other drugs versus ACE inhibitors versus other drugs. The first thing to say is that many of these trials include combinations of ACE inhibitors with other drugs rather than just ACE inhibitors alone, and the same is true with ARBs. So it's very difficult to tease out differences related to an ACE or an ARB in these kind of jumbled up data that are used for meta-analysis. I don't think they're robust, and I'm not convinced that we should base treatment decisions on them. We should use the trial evidence that we have of the direct head-to-head comparison in 25,000 patients, which I would review as definitive. The second thing I would say is if you go back into the literature and look at the trials in which ARBs are being compared against placebo, as the ACE inhibitors were done when they were being developed, in terms of heart failure, post-MI, the data looks identical to the kind of risk reductions we saw with the ACE inhibitors. So I'm not convinced, personally, that there are any significant or important differences in outcome between ACE inhibitors and ARBs from these trials. I think the main difference between the drugs is on durability of effect and on side effects. I think the Ascot study was a great study. I mean, the main reason we did the Ascot study was to look to see whether newer treatments that were emerging, calcium channel blockers, ACE inhibitors, would give us a better outcome compared to the conventional drugs such as beta blockers and diuretics, which were the most commonly used treatments in the United Kingdom and many other parts of the world for hypertension. So we directly compared starting treatment with a beta blocker, atenolol, versus a CCB amlodipine as a single treatment. And then, if required, the add-on therapy was a CCB to the ACE inhibitor and a diuretic, bendraflumetazide, to the beta blocker. So we ended up with effectively with most of the patients on 2 drugs for the treatment of their hypertension. And then if further drugs were required, we then added in doxazosin in either group if needed, and then spironolactone. So there was a very structured process of adding on therapy. My take from the data and the results from the blood pressure lowering trial of Ascot is that the combination of newer agents, so using a CCB with a RAS blocker, was more effective at reducing stroke in particular, but also less likely to give rise to diabetes in patients with hypertension, and therefore had a significant advantage over the older therapies, beta blockers and diuretics, which had been using at the time. Now, other trials had already begun to show a similar thing. So, for example, the LIFE trial, which used an ARB as the initial therapy versus a beta blocker with add-on of diuretic and then CCB, also showed superiority of a RAS blocker strategy with a diuretic in this case, or a CCB if needed, versus a beta blocker diuretic. And this led to the UK guidelines recommending that beta blockers in particular should no longer be considered an initial therapy for hypertension. So I think what Ascot did is it confirmed the superiority of a modern treatment regimen over what was at the time standard care, beta blocker and diuretic. And what it's led to, I think, is a wider use of RAS blockers in combination with diuretics, or more recently in combination with CCBs. And I think that's what Ascot told us in terms of the blood pressure lowering trial results. It's important to say it wasn't a fixed dose combination trial is often quoted. It was actually a trial which had stepped care, in which we started with one drug and added another. And we were directly comparing old versus new types of therapy. And I think what it's done is it's added to a substantial weight of evidence supporting the guideline that NICE has recommended, which is the preferred use of a RAS blocker, either an ACE or an ARB, with a CCB for the majority of people with hypertension, or with a diuretic if needed, particularly in people with edema or heart failure. So I think it added to the body of evidence that supported that recommendation. And I think that is the right recommendation and the way to think about it, that you have the option of using either an ACE or an ARB with a CCB or a diuretic, or all three if needed, in people with more resistant hypertension.